We will bring this special assembly meeting to order for May 29th, 2004. This is a special assembly meeting, joint meeting with the Bartlett Regional Hospital Board. Madam Clerk, will you call roll?
Thank you, Madam Mayor.
Actually, Madam Clerk, why don't we save the roll call for introduction, just note the roll.
Okay, that works for me. We do want to check everyone's sound who is on
Okay.
Zoom, though, if you could, Madam Mayor, if you wouldn't mind. Ms. Atkinson, can you check your sound, please? Can you hear us and can we hear you?
I can hear you. Can you hear me?
Yes, we can. Thank you. Walaki Doc, would you like to check your sound, please?
Sure. How's that sound?
Yep, we can hear you. And Ms. Deering,
I can hear you.
can you say something again? It cut out on you.
I can hear you.
Okay, we could hear you as well. Thank you. Madam Mayor, roll is so noted.
All right, thank you. Next, we'll have public participation on non-agenda items. So these are nothing to do with the hospital. If anybody's signed up for anything that has nothing to do with the hospital, now would be the time to raise your hand because I have the sign-up sheet. Seeing none, we'll move on to agenda topics. So first we'll go with introductions and we'll start with Mr. Solomon Gross. So basically we're looking at who you are, how long you've been on the board, and not much else.
My name is Kenny Solomon. Oops. My name is Kenny Solomon Gross. I've been on the board. This is my 6th year. I'm currently the president of the board, and this is my 4th year serving as president.
Thank you. I'm Mayor Beth Weldon, as people probably know that. Ms. Hale.
Michelle Hale, Deputy Mayor.
I'm Hal Geiger. I think I'm in my 4th year of membership on the Bartlett board.
Greg Smith.
Deb Johnston. This is my 6th year on the board, and I'm the vice president.
Paul Kelly. I was elected in October to the Assembly.
I'm Max Mertz. I've been on since July of 22, and I am the finance chair.
And my name is Ian Worden. I'm the interim CEO of Bartlett Regional Hospital.
Christine Wall. I am on the Assembly. I just started my 2nd term.
Alicia Hughes Gandes, Assembly member for about 5 years.
White Bryson. I'm in my 6th year on the Assembly.
I'm Lisa Peterson, and I have been on the hospital board since July of 22, starting my 2nd year. Thank you.
Hi, John Rastor. I've been on the board for about 15 months.
Wade Bryson is also our hospital liaison.
That's all
Thank
right.
you for doing that too.
That's all good. So with that, we will go to public testimony to start with before we have any kind of discussion. And would you please pull up, I think we have one on Zoom, correct, Mr. Johnson? Mr. Johnson, please state your name and area of town you live in for the record, and you have 3 minutes.
Thank you. My name is Mark Johnson. Can you hear me?
Yes, we can.
Thank you. I live 10726 Horizon Drive, North Douglas, Juneau. I'm a former hospital board member, so greetings to all Mayor Weldon, Assembly members, and hospital board members. I sent an email to that most of you hopefully have seen about the funding for the behavioral health issues. And I just have a few additional comments that I'd like to add. I have a long history as a family member with behavioral health dating back about 36 years with family. And when I was on the board, it was one of the primary interests of mine. And so I'm obviously concerned about the current financial crisis that the hospital is experiencing. After listening to the board last night, I had a few additional questions and comments. And also would just like to say that, as usual, I think a crisis gives us the opportunity to assess where we are and to where we could be in the future, and to realize how much progress that we've already made. And in a financial crisis, we can either cut programs and services and expenditures, or we can grow those services to achieve economies of scale to help achieve long-term financial stability. That's my hope that that would be the goal for this behavioral health in Juneau. We could also provide more services for people outside Juneau, which would help us achieve those economies of scale. With the new crisis stabilization facility, for example, I heard last evening that it's not capable of physically separating adults from kids, and therefore it's not serving adults. I was curious about that because from the very beginning of planning for that facility, dating back to CEO Chuck Bill, we talked about designing the facility so adults and kids could be separated. So I don't know why it's in that situation now. I also heard that it's designed as a voluntary crisis center and does not have locked rooms. My understanding is that Crisis Stabilization Center meeting National Substance Abuse and Mental Health Services Administration standards should have lockable rooms for patients in acute crisis. I'm not sure, but this may affect reimbursement rates. I wonder again how the decision had been made. Other existing behavioral health services are critically needed, including Rainforest Recovery Center, Bartlett Hospital Outpatient Services, the Adult Mental Health Unit, and the Applied Behavioral Analysis Program. And eventually, I actually think that we should consider longer-term secure residential treatment for kids like we already do for adults. I was just released from the hospital a few days ago, and while I was there, I was told that there were actually 2 kids on the medical surgical floor who were there for mental health issues. I heard the CFO, Joe Warner, say last evening that grants are not included in the financial projections because they're not dependable. I am not an expert on behavioral health grants, but I know from experience that public health that some federal and state grants have continued for several decades.
Mr. Johnson, your time is up. Wrap up.
All right. Okay. Well, I just hope that we can find a solution, but my recommendation is that we establish the chief behavioral health position, because I think when that position was in place, we were growing our services, and when that position was deleted, services start to degrade. So thank you.
All right, thank you. Any questions for Mr. Johnson? Seeing none, thank you for your testimony tonight. Next, we'll come into the room, and I apologize on this one, Aaron Surma. You want to come up here?
For those that are coming up to testify, the microphone is right here. If you hold it about a hand's distance away from your mouth, don't try and eat the microphone, it does better. And you press the little green and red button at the bottom. When it's green, you can speak.
Great, thank you.
Please state your name and area of town you live in for the record, and you have 3 minutes.
My name is Aaron Surma. I live 4001 North Douglas. I'm here as someone who has struggled with my mental health since I was a teenager. At my least healthy, I've been arrested and received every type of service that Bartlett provides. Because of the care that I received when I was younger, I'm here in front of you today. And without that care, it's unlikely that I would be in a condition to speak with you. I'm also here as the director of NAMI Juneau and the Juneau Suicide Prevention Coalition. Here are some of the impacts that I see if these programs no longer exist. We receive hundreds of calls and emails from people asking how to receive behavioral health services in Juneau. My first question is, do you have private insurance? If you do, you have a chance to find outpatient treatment right away. If you have Medicaid or are otherwise uncovered, you're faced with long wait lists. Closing BOPs would make this disparity worse. We train people to use their lived experience with substance use to support others in recovery. Most stories start with incarceration before moving to treatment and then advocacy for others. These people enhance our workforce. Rainforest plays a central role in many of their stories. Losing Rainforest would make treatment and hope an even more distant idea for people struggling with substance use. The Crisis Stabilization Center at Bartlett is a crucial piece of our mental health continuum of care, both to provide a local support for the 30% of Juneau students who reported being suicidal in the past year, as well as adults who are struggling in public who would benefit from a safe, stable place rather than jail or another nights on the streets. These services are vital, and these are my words. This afternoon, I asked people who receive services at Bartlett for their thoughts to share, and here are some of their words. First, BOPS was the only place with a psychiatrist who was willing to support my daughter while she was titrating off a medication that is notoriously difficult to stop. No other psychiatrist in town was willing to help her. Second, Those of us with mental health and substance use issues in Juneau and Southeast Alaska will not go away. We will just be served in the emergency room, gobbling up more precious resources without the real treatment now being provided by BOPS, crisis stabilization, and rainforest recovery. The rapport that I had with staff at Rainforest Recovery was excellent. I am now 4 years sober because of their help. And fourth, in September of 2022, I attempted suicide for the second time and was placed in the MNICU for 72 hours before transferring out of state. Bartlett's outpatient care ensured that my recovery was not impacted by many changes in my life. If not for their services, I would not be alive today. Back to my words. I'm not close enough to the situation to even guess at the best solution for keeping these programs in our community long term, but I know that the mental health services at Bartlett Hospital are the definition of an ounce of prevention is worth a pound of cure. I hope we're able to find a solution that keeps these resources in our community. Thank you.
Thank you. Any questions? Seeing none, thank you for your testimony tonight. Next, we have Abby Spofford. Please state your name and area of town you live in for the record, and you have 3 minutes.
My name is Abby Spofford. I live in the Valley. Assembly and board members, I am testifying today to urge you to support outpatient mental health programs at Bartlett Regional Hospital. My name is Abby Spofford. I'm a resident. I'm a homeowner. I'm a wife, a daughter. I'm a dog mom, and I suffer from severe mental illness. 282 days ago, I found myself needing immediate access to mental health treatment. I could no longer advocate for myself. I had exhausted all options and I needed help. I walked into the cold, sterile mental health unit at Bartlett defeated. For 48 hours, I searched with the help of my caseworker for any program that could help me upon discharge. My support system made endless calls to programs around the country, my insurance company, and finally helped me find a program that helped me stay alive to be right here in front of you today. As so many people advocated for me while I was not able to advocate for myself, I am here advocating for those that can't, for teens, for friends, for families, for your coworkers, those unable to leave Juneau for basic medical mental health care. May is Mental Health Awareness Month. I want to ensure that you are aware that mental health matters. Access to care matters, and the cuts that you are proposing today to the outpatient programs could have catastrophic effects on our community.
Thank you. Next, we have Christy Doyon. Please state your name and area of town you live in for the record, and you have 3 minutes.
All right. Good evening. My name is Christy Doyon. I live in the Valley. I've lived in Juneau for 3 years. Full disclosure, I am an employee of Bartlett. However, I'm speaking representing myself today as a Juneau resident. As you know, addiction affects the lives of countless people in our communities. Not only the individuals who suffer from addiction, but the many people their lives touch, including family members, employers, and neighbors. Rainforest Recovery Center has improved and saved thousands of lives since its inception 40 years ago, and I'm going to let the other people speaking tonight share some of those critical stories. I want to encourage the CBJ Assembly to listen to their stories with an open mind and an open heart tonight, and at the public hump nights on June 4th and June 10th. Rainforest Recovery Center is a co-ed 16-bed, co-occurring 3.5 level residential facility accepting patients who voluntarily seek help with mental health and substance use disorders. It is the only high-intensity, short-term program in the state of Alaska and the only high-intensity 3.5 program in Southeast Alaska. For those of you who are unfamiliar with treatment levels, a 3.5 level program helps stabilize people, both mentally and physically, before stepping down to a less intensive 3.1 program, such as the Gastineau Human Services, or sober housing, such as Tlingit and Haida Entry and Recovery, where there they will focus further on continued treatment and reintegration into the community. When Rainforest changed hands from CBJ to Bartlett 20 years ago, Bartlett received subsidization from CBJ at over $1 million a year, coming in part from alcohol and tobacco excise taxes to help fund Rainforest Recovery Center. Over the last 20 years, that amount slowly decreased. Most recently, in 2022 and 2023, Bartlett received $518,000 a year from the tobacco excise tax. This year is the first time Bartlett did not receive any subsidization from CBJ to help fund Rainforest. Behavioral health and addiction treatment programs are not profitable. With a statewide average of a 40% reimbursement rate for services from Medicaid, co-occurring substance use treatment programs, such as Rainforest Recovery Center, will continue to be dependent on grant funding and subsidization to break even and continue saving the lives of people participating in their programs. Thank you.
Thank you. Any questions? Seeing none, thank you for your testimony tonight. Next, we have Rebecca Mills. Hello, please state your name and area of town you live in for the record, and you have 3 minutes.
My name is Rebecca Mills. I live just outside of the downtown area. For full disclosure, I am an employee of Bartlett Regional Hospital. However, tonight I am showing up as a community member of Juneau, sharing my own personal views. I've lived in Alaska since 2018 and relocated from Sitka to Juneau in 2021. 3 years ago, in May of 2021, the CDC's count of drug overdose deaths in Alaska over a 12-month period were reported at an astonishing 188 individuals. By November of that same year, the number of drug overdose deaths in a 12-month period had nearly doubled. 253 Alaskans were lost during that period. The most recently updated statistics reported 356 Alaskans lost over 12 months to drug overdose deaths. These deaths do not include deaths due to alcohol consumption or illnesses secondary to drug or alcohol use. The ripple effect felt in Alaskan community families and communities cannot be overstated. To have the courage and resolve to enter a residential treatment program, the motivation has to be high. For some individuals, this means facing and resolving legal involvement, keeping someone from participating in the workforce, or causing challenges accessing housing. Some are desperate to reunite with their children following countless years of generational trauma and are ready to fight this disease and break the cycle. Others are urged by friends, family, medical providers, or employers to seek help. Others simply wish to have the opportunity to be sober for the final days of their lives. Having access to a residential treatment program can mean the difference between these individuals meeting their goals and regaining control of their life or running out of time before they can do so. For some individuals, the road to sustained recovery can require leaving one's home community to seek care in another Alaskan community, if they are fortunate enough to be accepted and have an opportunity to wait, sometimes months, for a bed to be available. For others, the fear of leaving their community or lack of resources to do so can be crippling and lead to continued use and other societal consequences felt by our community as a result, including increases in domestic violence, interruptions in the workforce, the involvement of protective services, and countless other impacts. If an individual is placed in the level of care provided by Rainforest Recovery Center, it means that they meet criteria which has established that they are not able to maintain sobriety independently without 24-hour support and care provided at that time. In order to get to the point where the levels of care offered in Juneau outside of Rainforest Recovery Center can make a difference, completing a program such as RRC is necessary for those individuals. I call on the City of Juneau to explore funding solutions and consider reinstating allocation of funds previously provided to support the operation of Rainforest Recovery Center, which has been a community resource for Juneau for 40 years. This will continue to support individuals most vulnerable in our community and provide continued equitable care for the most underserved individuals. Thank you for your time and consideration.
Thank you. Any questions? Seeing none, thank you for your testimony. Next, we have Jenny Brown. Please state your name and area of town you live in for the record, and you have 3 minutes.
My name is Jenny Brown. I live in the Valley. I'm here to speak on, I don't have anything written because I feel like it comes more from the heart. I'm speaking on the services for Bartlett that are much needed in every community. Juneau is the hub for Southeast. In the last 8 months, I've lost 16 people. 14 of them are drug overdoses because they couldn't get into services fast enough with rainforest recovery. People that have, I'm a person in long-term recovery. I have 7 years clean of opiates and prescription medication. I'm also formerly incarcerated. I've spent 13 years in and out of Lemon Creek Correctional Center. And I'm here to advocate that these services are vital to everybody in Southeast, everybody in Alaska. This is needed. This is needed to save people. This is needed, we're needed to be the hand that stands there to help people come into these services. Everybody needs that helping hand. Everybody needs these services. They're vitally important. My sister passed away in August of this last August, who was going to come to Rainforest but couldn't get in fast enough. Fentanyl was part of the reason of her death. This is everywhere. This is everywhere in Alaska. It's everywhere in Juneau. It's being sold on the streets for $3 a pill. Things like this are needed. The hours of people in active addiction aren't 8 to 5. They're the 7 p.m. to the 7 a.m. That's when they're needed the most, when these services are needed for everybody. I really want to advocate on how important this is. I feel like if I was still in active addiction, I wouldn't be here. I wouldn't be here at all. I wouldn't be here to stand up for the people incarcerated, and I certainly wouldn't be here for the people that don't have the voice to speak, that can't come forward, that are no longer with us. This is something that needs to stay open. This is survival for some of us. This is the resources that we need to be able to take the next step to come back into the community. Not everybody's going to make it. Not everybody's going to be there. But if we have services like this to stay open, there's a better chance. They have a fighting chance to be in here. Thanks for letting me talk today.
Thank you. Any questions? Seeing none, thank you for your testimony. Next, we have Mary Alice McKean. Please state your name and area you town you live in for the record, and you have 3 minutes.
Is it on? Hello, my name is Mary Alice McKean. I live at 212 West 9th Street, and I've lived here since 1978. The reason why I'm here is to speak on behalf and in favor of the continuation of hospice services, particularly for dying people. I was really struck by this headline in the Empire, which said Bartlett Regional Hospital looking at eliminating or trimming 6, quote, non-core programs to stabilize finances. And I realize now that maybe non-core has a specific hospital function, but my immediate reaction was that hospice services are a core function. I can't imagine a city of 30,000 people not providing, as part of its healthcare system, hospice care. People who are dying need specialized care. Their families need specialized care. And it's inconceivable to me that we would go back to where the only option people had was dying in the hospital or dying at home without expertise and without help. When surveyed, 71% of Americans feel that, quote, helping people die without pain, discomfort, and stress is the most important aspect of end-of-life health care. And the same survey said that 71% of Americans would prefer to die in the comfort of their own home. I was really relieved when Bartlett took over, or after Catholic Community Services stopped, when Bartlett took over this function. It is a core function for a civilized society at this point to offer people the option to die at home with care and dignity. And I just think we have to continue that in our town. Thank you.
Thank you. Any questions? Seeing none, thank you for your testimony. Next, we have Bob Urata. Please state your name and area of town you live in for the record.
My name is Bob Urata. I live at near the hospital, Twin Lakes. And what was the other thing I was supposed to say?
You had 3 minutes.
Oh, okay. So now I start my testimony. So hospice and home care saves healthcare systems money by getting appropriate patients home early, heal faster, reduce readmissions, and patients and their families like it. The goal is to prevent institutionalization, get home early, and to maintain patients' independence. It lowers hospital costs, labor costs. It provides personalized care to treatment, home health, monitors patients at home and their conditions, and provides preventative care early before they get really sick and have to be hospitalized. It provides high quality of care by a team of caregivers, including physical therapists, nurses, speech therapy, social worker, with oversight by a physician. So it's a whole team. It provides wide ranges of services like wound care, nursing care, physical therapy, occupational therapy, and medication management. The goal of hospice care is to maintain a full life after a terminal diagnosis. Comfort care and dying at home with family is an important part of it. It reduces suffering, and then after the passing, it provides bereavement care. A little bit of history. Juneau has had this care since mid-1980s, and Carpenetti was its first board president. And I got involved somewhere around 1987. I think that hospice and home care should be an important and valuable part of the core services at Bartlett. Thank you.
Thank you. Any questions for Dr. Urata? Seeing none, thank you for your testimony tonight. And since I ended up with the sign-up sheet, is there anybody else in the audience that wanted to testify that didn't get a chance to sign up? Seeing none, we will move on with our agenda. So, Bartlett Regional Hospital Recovery Plan. President Solomon Gross, is that you, or are you going to?
Yes, I'm gonna start off here, Mayor Weldon. Thank you very much, and thank you very much, Assembly and fellow board members. First of all, I kind of want to start off by saying that we as a board really know the responsibility that the Assembly has put on us to make recommendations to the Assembly for our community on how we're going to deliver healthcare to our community and for our community hospital. We are very fortunate right now that we've got a great interim CEO that came in here and was able to look at our finances, and we were able to get a great CFO to come in here and see what we can do to make sure that Bartlett stays sustainable. Our fiscal responsibility as a board is one of our number one things that we're supposed to do, but also is to make sure that our community has what we need and making sure that we're able to provide that for the community. One of the best things about having a community hospital that we all own is we, as a community, get to choose what services we want for us. So as I'm going to turn this over to our committee chair of finance, Max, board member, to go over our sustainability plan, our recovery plan, knowing that this is with the input of the board members, with staff, and during the next month, we're going to have several outreaches to our community, so we'll be able to come to the hospital and meet with us, meet with the board, and tell us what you want for us, so then we can come back to this body here and make sure that we're able to tell you our thoughts and our recommendation to the Assembly as we move forward. So with that, I'm hopefully the board members will speak up here as Max delivers this. If you have any thoughts on this, make sure that our thoughts go out to the Assembly members, and we really look forward to the Assembly asking us questions and working with us on this. So with that, I'm going to turn this over to Max. Mr. Mertz.
Mr. Mertz.
Thank you, Kenny. I want to just start by saying that Joe Warner, who is our CFO, is the author of these slides. He and I and finance have spent a lot of time on the details here and also the background and the history, but he has a 8th grader graduating from middle school tonight, and so wasn't able to join us. So I don't know if anybody saw the movie Stripes from the 1980s, but I was the guy that didn't step backwards when he asked for volunteers to do this. So it's on me. Although it's very much a group effort. I also want to start by saying that that we've all been through a pandemic. The pandemic was especially disruptive to healthcare entities, and certainly Bartlett wasn't exempted from that. Going into 18 and 19, actually things were pretty stable for the hospital. We had profits in those years of around $4 million, and it was performing reasonably well. And a couple of things happened during COVID. One is that the traditional services that the hospital provided had to be literally set aside and replaced with services that could be provided during COVID to be responsible to the needs of the community at the time. And one of those, of course, was outpatient behavioral health services. I mean, that was a major need during COVID, and the inpatient mental health services were set aside. As an example, Rainforest Recovery was hit, and during that time, so the traditional revenues that the hospital earned by providing services starting in 2020 literally evaporated. And there was in CARES, a component of the CARES Act, and 2 follow-on acts was something called the Provider Relief Fund. And the Provider Relief Fund was a mechanism for the federal government to basically supplant that revenue to provide it for the hospital. That revenue went poof in 2022. And so the hospital found itself, and like a lot of providers, most providers around the country, with a new paradigm for how it was providing services that weren't reimbursable. So we went back, if you think about mental health, a day of mental health inpatient services at Bartlett pays $5,000 a day. That's the net reimbursement. You get for some of the behavioral outpatient services $100 for an incident. Some of them are more than that, but certainly it's a significant impact to the revenue that we're getting from those services. And throughout the hospital, there's corollary examples of that type of thing happening. So let's add another layer to that. And the other layer was we've had a lot of turnover and a lot of drama, if you will, in management. We've had several CEOs during that period of time. I think the Bartlett board bears a certain amount of responsibility for that. I think, it's also a matter of just chance and what happened, but nevertheless, it's been very disruptive. And when you put those two together, now we have, as Kenny said, a very capable interim CEO and that has, come in and starting to put some pieces back together. I do want to say that we have extremely good staff. I mean, our senior team to a person is excellent. I mean, these people are very committed, dedicated people who are very good at their jobs and are very good, in their roles that they're trying to fill. And so we come on the backside of this with that staff and find ourselves now looking at a $10 million loss. So, Massimino in that ballpark, $10 million. We have 3 years of cash left from today, 3 years of cash before we're closing the doors. Essentially, we're not able to make payroll without a significant adjustment to the way that we're operating. So we're left with very stark choices about how we want to move forward to have what I'm committed, and I know the rest of the board is committed to having a strong, independent hospital for the next 20 or 30 years and for our kids. So that's why we're here. And the idea of looking at the component parts of the hospital and which of those are the types of things that when Ms. McKean talked about core services. core services are the types of things that you normally see a hospital doing. You know, they're ER, they're inpatient things for when people get off a boat and they've got norovirus and they need to get rehydrated. They're acute care services, they're labor and delivery, they're, you know, oncology services, all the typical things that a hospital provides. The other services that are not part of that core are services that typically you see other providers in most communities doing. That's not to say that they're not vitally important. I think to a person, we all feel like these are extremely important services, and we share what the feelings of the folks that have spoken tonight. And so, you know, what's the right landing spot? And that's kind of where we are. So Joe, if you'd go to the next slide. Actually, before we get off this slide, I do want to just point out that we are on the 29th tonight, obviously. We have 2 community feedback. Let's see, one of those dates doesn't look right, Aaron, on there. Yeah, it's June 4th and June 10th, or is it the 19th? Yeah, gotcha. Okay, thank you. Yeah, so the 4th and 10th, we'll be doing some more public input, and then we'll be meeting again as a finance committee to consider that, and then hopefully by the 25th of June be at a point where we're making recommendations to the city on
Mr. Mertz,
possible directions.
can you talk about that public outreach on the 4th and the 10th? What does that look like and where is it going to be held?
Yeah, so I'm going to have, Ian, do you want to fill that in?
Yeah, I'm happy to. Thank you. Happy to. What we are going to have is 2 open meetings where people can come. That'll be at the hospital in our education rooms with spillover into our boardroom so they can see it. People can come and make comments. And we will be advertising that so that people will know that this is available to them. And we would support everyone that has feedback to give us to come to those meetings. It'll be really important to help us understand what the impact of our decisions will be. So that's going to be kind of the general way that we're going to do it. We also are getting letters in, and we are going to be packaging them up for the board so they can read them all at once we have all those. So there's a number of different things that we're doing.
Will your meetings have Zoom components to it? Will your meetings have Zoom components to it?
Yes.
Okay, thank you. Ms. Hale, sorry.
Thank you, Madam Mayor. Thank you, Mr. Mertz and Mr. Warden. At the meetings where you are taking comment, will there be information available, like, for example, the packet in front of us, so that people have some sense of, sort of, an organized sense of the material?
Absolutely. What we've tried to do is present everything in the same exact format for all of the different parties so that every individual that can comment, or any individual that we've discussed it with, for example, like the medical staff, our own employees, they're seeing the same information that the board sees and that you all are seeing tonight. For different various reasons, we may change the order of it, but the content will not change.
Mr. Solomon Gross.
Thank you, Madam Mayor. Again, to just capitalize on what Mr. Warden is saying, that this is a live document, so we will do a presentation at each one of these community outreach. So the document will be updated each time that we go through there, so it'll be online too as well. So
Thank you. Ms. Hughes-Candies.
Thanks, Madam Mayor. So just so I'm clear, the 4th and the 10th will be those 2 public meetings with distance components. And then the May 29th through the June 19th, that's accepting comments all through that via email or?
Did you have something? Okay. All right, continue, Mr. Mertz.
Thank you. Next slide, please. We have a strategic plan, and this is one of a very long document that is just summarized in these different bullets. And I don't want to spend really honestly any time on this other than to say that Mr. Warden and his staff have worked very hard flushing this strategic plan out to the point that we received an update on this last night. They've drilled it down so that each one of these has components that are measurable, and within those components that are measurable, there are key performance indicators, KPI. And for those KPI, they've got basically a monitoring device that is kind of a color-coded monitoring device that allows them to see how they're doing. And that's posted in a public place. And so it's a great tool, I think, and it was great to hear that that's moving along. Having said that, I'll leave that. If we could go to the next slide. I'm going to try to be concise tonight. I will do my best to be concise. If there's questions that you have as you go, please feel free to chime in. I want to make sure that we have enough time to answer any questions that you have and get it out there in a consumable kind of format in terms of what we're looking at here. So a couple of these, I'm gonna go back and look at a little bit of history because I think history is important to understand on a couple of the items. And I want to start actually with the one that's not in the red box, which is to the left, which is the hospital and welfare court combined. So this is what, as we've deemed for definitional purposes as the core of the hospital. And as you can see, the upcoming budget has a loss of $2.85 million. As we're spending a lot of energy on these other 6 things that you see there that are the non-core services, just please know that there is a lot of work, a huge undertaking happening with respect to each one of these. And I'm going to just touch on 2 or 3 of these just to give you kind of a flavor. First of all is inpatient and outpatient. We'll touch on this more, but one of the big drivers from a revenue standpoint and a very important part of our hospital is inpatient mental health unit. It took a major hit during COVID. I mean, it's a 12-bed inpatient mental health program that typically had an average daily census, so number of patients that are filling beds of around 10 or a little bit better, actually. That was kind of the historical average for that. It went down to 2 during COVID. It was very low. And with that went $5,000 a day of revenue. You can do the math and see the impact that has on the hospital. So what happened during that time is that entire effort, if you will, was shifted to an outpatient basis. Shifting that back now post-COVID is not an easy undertaking. And it's something that we're trying to do because everybody understands the importance of outpatient services. And I will be talking about that more. But that has been a major effort of the hospital is encapsulated in that MHU example, taking this, what was pre-COVID operations and getting us back to that. And there is a tremendous amount of work. I'm sure if Kim McDowell, who's sitting right over here, was sitting there, she could give you several hours on, the work that they're doing around that. So that's one example. The next one is staffing. So COVID also required increasing staffing for a variety of things because we're doing distance, because of the difference in services that we're providing, the outpatient types of stuff that we were having to get into. There was, kind of a management piece that was part of that. And so there's been a real effort around a reasonable reduction of FTEs back to a level of pre-COVID. And with that comes a reduction of costs, but doing it in a way that we're not doing layoffs, we're not, it's as we have vacancies and opportunities present themselves. And so that has been a major focus. There is an FTE committee that meets on a regular basis. And again, Ian or any of the staff could give you a lot of long dissertation about that. A third area is something called critical access. Critical access is a CMS designation for smaller hospitals that allows you to get full cost reimbursement for all the services that are provided to the hospital. Right now, we participate in something called the demonstration program, which is something that kind of a carve out that was done many years ago by Congress that allows us to get inpatient cost reimbursement. It doesn't apply to outpatient cost reimbursement. So if we convert to if we're able to convert to critical access, we'll be able to get cost reimbursement on outpatient as well. So instead of getting paid, if you will, on a kind of a fee schedule, they look at, what are your actual costs of providing services, and that's what you reimburse. And it's the impact to the bottom line would be sufficient or be significant. It's a very complex conversion. We are months away from that final decision, and we have hired a firm called Hall Render, which is a national through Mr. Palmer, hired a firm called Hall Render who has great expertise in this, and they've given us a work plan on what we need to do to get there, and we're pursuing that. And it's with the goal of that $2.85 million, all these things, and there's others that I haven't mentioned, of bringing that from a loss of $2.85 million to about a 4% of revenues bottom line. I mean, as a healthy healthcare facility, you can't do zero. Zero doesn't allow you to replace equipment, and it doesn't allow you to replace facilities. It doesn't allow you to do things that training and some of the stuff that you really have to do to provide strong services. So if you take that $138 million on the top line up there, which is our net revenue, and you multiply that by 4%, you get somewhere around $5 to $6 million of bottom line. So really what we're going from is about a $3 million loss to about a $5 million. We got about an $8 million turnaround that we need to do, and that's in the core. So we're focused on these other 6 areas, but just know that we're working like crazy on the other ones as well.
Ms. Wall.
Thank you, Madam Mayor. Super helpful. I'm really glad we started on the leftmost column here because that was some of my questions. That goal that you're talking about in terms of positive margins, and maybe it's too early to tell, but what time frame are we talking about to get to that place that you're thinking we can get to?
So I would say it's incremental. So there's an aspirational goal and there's a realistic goal. Aspirationally, I would like to see within a couple of years of us being to that point. If that's real, if we're able to have a good landing spot around critical access as well, I would say that's sooner than later. All of the FTEs need to be done in what I kind of think of as a kind way, so that we're doing it so that it's not disruptive to our 600 employees. And some of these other things that we have to do around performance metrics and those kinds of things, you have to do in the right way so that you get employee acceptance, and you've got to do those in a way that's not, harmful to people. And so I think 2 years is probably reasonable. It's something I think we could all shoot for. And depending on how quickly this critical access thing can come, potentially that will get us there a little quicker. Does that answer your question?
Ms. Hughes Candies.
Thanks. Just a variation, same question at heart. Given that, and there's aspirational and there's more realistic, would you spitball when you might be like breaking even and not at a loss? Because you talked about an $8 million positive margin.
So I guess I'm not trying to avoid this, Ms. Hughes Candice, but I'd like to pull together a solid estimate for you. And it really needs to come not from your finance guy that's subbing in for your CFO. And I can tell you that we're working like crazy because we need to get there. And every month I have a sit down with our CFO. We go through the books in detail. And recently we've had some pretty good results. We're seeing basically break even now during the summer months, but winter is when, you make money in the summertime, and then the wintertime is a little tougher. And so, and that combined with, the progress that we have, how well are we able to maintain 10 people in the MHU? How well are we able to have a good landing spot on FTEs? There's so many moving variables. I just think that probably really needs to come from Mr. Warner and Mr. Ian spending a little bit of time on that estimate. Okay. Okay, Rainforest Recovery Center, and I'm gonna go back in time here a little bit.
Mr. Smith?
Thank you. Sorry, I was a little late on the draw there. Mr. Mertz, the transition, I think you call it critical access, to transition to critical access hospital, would that affect positively, should that transition happen, would that affect revenue numbers of the six?
No, and in fact, it actually has the opposite effect that you would think it would. So cost reimbursement for the center facility is based partly on the administrative costs that you incur for the hospital as a whole. Administrative costs are relatively fixed, so you only need one CEO, you only need one CFO. You got an admin function, you got a billing function. Those are fairly stagnant. You got an IT function. So when you take those costs and you allocate those out over the other facilities or the other activities, which under federal law you have to do when you prepare a cost report. So you take some of that and you move it out to all these other ones. What you're reducing is that administrative base that results in the reimbursement that you get for the critical access component. So what it does is, to the extent that we have these other functions in place, it reduces those. So not to say that it doesn't make sense to maintain those. The other thing I would also add is that critical access is about getting us to a point where we can have net reimbursement, if you will, for the hospital welfare core component, which we're a long way from at 7 or 8 million. Does that answer your question? Okay. So rainforest recovery, there are some people that probably more knowledgeable than me about this, but I'm going to go ahead with my notes anyway. Was formed as Juneau Recovery Hospital in 1980, and it's a 16-bed program, and it was actually operated as a component of the city and borough of Juneau until 2000. Without getting into much detail, there was a change in the way that costs were reimbursed from a grant model to a fee-for-service model in the 1990s, and it made the revenue piece of getting paid for the services providing much more challenging for that. And the leaders of the city at the time felt the hospital was a much better place, so they actually closed the mental health. There was also chemical dependency. They closed chemical dependency special revenue fund, which is Juneau Recovery Hospital. They also closed mental health at the time and transferred most of that to JAMI. And then a part of that went to Juneau Youth Services as well. So there's two pieces that went away in 1999 being the last year. In its last year of operation, and I've got the financials here, the Juneau Recovery Hospital had $1,012,000 loss. So that was in 1999, $1,012,000. The city and borough of Juneau supplemented that loss with a $937,000 transfer. And that included general fund, sales tax, and tobacco excise tax, so $937,000. In addition, part of that, part of the revenue for the Juneau Recovery Hospital was $931,000 state grant. So in total, you had about $1.67 million roughly that was funding for that program that covered the $1 million loss and provided, the adequate operations that you needed to have for that. So on the next slide, if you'd go to that, please. And I know it's small on here, it's a little easier to see on your slides. Under the history and background, over time, so the first year that Bartlett operated that, it was a $1.67 million subsidy, and that subsidy has gone away. So we are, in 2024, it's $270,000. In 2025, it's zero. Also, during that period of time, the state grant has, and I don't have those numbers at the tip of my tongue, but the state grant has gone from $931,000 to a very small number. It's much smaller now. And so the result of that is essentially that we have a for FY25 for the budget, we have expected $1.8 million of revenue and $2.5 million of expenses, so around an $800,000 loss. The Rainforest Recovery Center there's some important metrics about that program that are very important to understand. First of all, 40% of the patient population for rainforest recovery is Juneau residents. So 60% are typically non-Juneau Southeast residents that are coming in that are using that program. And in the last 3 years, we've served 106 patients per year on average, 106 patients per year total, of which 42 roughly were Juneau residents and the rest were non-residents. Of those, and again, so we have $800,000 loss that the city is paying for, a significant number of which aren't Juneau residents. Of those folks, most of those are Medicaid beneficiaries, and 50% of those are search beneficiaries. We have only 25 patients over the last 3 years have received care over multiple encounters. So most of them are kind of one and dones, or people that come in and then they leave. And this is, again, based on the statistics and the information that I have. So it's just from a background standpoint, it's important to understand that this program has always been one, as one of our commenters said at the front end, which is exactly right. It's one that has always been at a, from an operating standpoint, operates at a loss. And there's typically been a lot of support from the CBJ that's allowed for that. I can tell you that there's a lot of support for the program, both on the board and in the staff and in the community, and we completely understand that. But we're in a position now where we're having to make hard choices, again, the eye on the ball around the $10 million loss. And so what do we do about that, And so this is one of the things that we certainly have to consider. So we have some, and they're listed on here as board recommendations. And last night we had some discussion around this at our board meeting, and I'd like to think of it as maybe a scope of possibilities, And so, certainly one possibility would be to find a third party that could take over operations of this activity from Bartlett. And there's a couple of things there. Number one is, who would that be? There's some possibilities in town. Jamie's one. There's probably some others that would be a possibility. Would they be able to operate it such that it still would require some sort of subsidy? Probably so, to keep it, at the level of service. The other thing that I would offer, and as a community member, and I was, the CBJ and the Bartlett auditor for 25 years, it's been under a big squeeze. I think if, for the folks that have been around and have provided services in the 80s and 90s and 2000s, we've squeezed the services there quite a bit over the several years. And is that a healthy thing? There's more to it than just, what is the, kind of the best outcome as it relates to Bartlett. If services are going to be retained by Bartlett, if we're going to continue to operate this, we have to have a subsidy. I don't know how to state it any other way than just bluntly say we got to have a subsidy for that.
Mr. Mertz, if you pause.
Yeah.
Ms. Hale.
Thank you. Mr. Mertz, could you explain what you mean by squeeze the program?
So anytime that there's pressure to reduce a loss, you have changes in staffing models. People, instead of, you could ask, we could provide you really good examples of this, but you have people that are wearing more than one hat. They're working in a couple of different, they're split between functions. They do different things. You've been through budget cutbacks as a state employee. I think you can probably come up with your own examples, right? And that's what we're talking about here.
Mr. Mertz, do we have a chief mental health person, officer? I know we had one at one time, but I know that person left. Have we replaced that position, or where are we on that position? Are we going to hire that position?
I'll refer that to Mr.
Looks like the president is tapping me, so
okay.
he's going to take it first.
So we did a gentle reorganization of our organization a few years ago, and the chief behavioral health person went away. Now we just have an executive director of behavioral health, so we don't have a chief.
But you saw the director.
So back to kind of the blunt statement, we got to have a subsidy. And, as the head of the finance committee, the reason I went back through the history is that you can look at the history and say, if we restore the funding through just kind of a normal mechanism in 2026, let's say FY '26, what's it going to be in FY '31, when you guys start having, financial issues? To me, it seems like there's got to be and I think we've used the word permanent, and I'm not sure that's the correct way, but and many communities use a dedicated funding stream, sales tax, property tax, a component of mill rate, to pay for services like that in their community. Whether Bartlett's operating it or somebody else, and the reason for that is so that you can have dependability. What we've lacked, frankly, I think, in a lot of these programs is stability. And to really restore stability in these programs, you need to find a mechanism that is going to be there tomorrow and 10 years from now. That's all I had for rainforest recovery.
Ms. Hughes, Candies.
Yeah, go ahead. I did have one thing, but you go ahead. No. If we did decide to close rainforest recovery, there are other providers. And I think it's just important, I'm not advocating for that or saying it's good or bad, but there are, for example, in Anchorage, there are 7 providers. So if these services went away, they wouldn't be in Juneau. There's no 3.5 level provider in Juneau. We have 3.1s. Somebody pointed that out. And 3.1s are being increased in size at Gas and Human Services within the next year or so. But there's no 3.5 providers. You'd have to go to Anchorage for that. So if the subsidy can't be found, if we decide not to do that, if we do close that, it does mean that patients would travel to Anchorage at least to find those services.
Ms. Hale.
Oh,
Sorry.
go ahead.
Ms.
Sorry.
Hughes, Candies, he didn't answer your question. Go ahead.
Thanks for that. I'm hoping you can speak a little bit about you spoke to the average per year that have been seen over the last little bit. And I know during the pandemic, we chose to voluntarily make the numbers in the facility small, the same way you had to adjust a lot of programs.
Yeah.
I'm wondering if you could speak to how that lines up against pre-pandemic, because I think you said 16 beds or 12 beds, 16 beds. And looking at the stuff that's on the State Department of Health and looking at what we have in Southeast regionally, it seems that there is a high demand for services and people can't get into beds. So how does that square against only seeing 106 people?
Yeah, so I just want to make sure I understand your question is, are we adequately staffing it to meet the demand? Is that maybe stated another way?
Yeah, are you operating at capacity, or if you're not operating at capacity, why aren't you operating at capacity?
Yeah, so I hate to say this again, but I don't have that answer, Ms. Hughes Candice. Do you, Ian, have that?
If we're not operating at capacity, then is there a reason for that?
Could we come up to the mic and please state your name? Please state your name and then talk.
Kim, why don't you have a seat here just to get yourself comfortable?
Well, I may have to rely on some of my colleagues back here. They have been running at capacity, but recently they have not been over the last few months. Say again? And part of that was because of having provider issues available to be able to screen the packets and get patients in.
Go ahead, Ms. Hughes.
Follow up on
And that, just a second, and that was Kim McDowell from the hospital talking.
Yeah.
Thank you, Madam
Kim
Mayor.
McDowell is our,
Chief Operating Officer.
yeah, she's our chief COO and our chief.
And then a follow up on that. So is 106 people a year? That is a number, that's a max number that you would be able to hit?
So far in FY '24, we've had 133 individuals served, and I would imagine some of those might be repeats. Is that correct? A few repeats, yeah, a few repeats in that number.
So I think what you're hitting is more or less we're at capacity.
But we're
Exactly.
already up beyond what you said you were getting served for the last 3 years.
Yeah, I'm talking about now. Yeah, so today.
That's confusing to me also, so let's try that again.
So if we're at 133 for the year, that tells me that 106 is not, if that 106 is your average and you think in general you're operating at capacity, but you're already higher than that, then that makes me question really, if, again, if you went back pre-pandemic, and then what is really like, I would be curious to see what those higher numbers are when you're operating at what you believe
Fair
is
enough.
max capacity.
Yeah, we can, Kim, do you have those with you now? Yeah, we'll probably have to provide that to you. Let's just see what the answer is. You turn it back on there.
Ms. McDowell.
Thank you. So we just recently went up to capacity. They had been capped at 8 beds prior, for various reasons. Some of that was provider. So they've just now been able to function at full capacity with, being able to take up to 16 residents. Correct.
So we'll just say that a little louder.
Sorry, the budget anticipated that level of volume, so the numbers that you're seeing is the projected budget that we have. So that's the budgeted loss. The other thing that's important to note, if you're above capacity and all of those are Medicaid patients, all you're doing is adding losses because the state pays around 45 cents on the cost dollar. So adding capacity doesn't necessarily help you on a financial standpoint. It does help you on the standpoint of providing services.
So, since only, did you have a question?
I did have a question, but go ahead.
Since only 40% are general residents, is there any way we can get money from the other communities sending us people? Or, I hate to limit it to just general residents, but is that a possibility?
That's a hard question. There needs to be a mechanism to recover it. I mean, you can't, if somebody's seeking care at the Rainforest Recovery Center, you're going to provide them care, whether the community's going to, I think you could ask a question about search reasonably. Should there be a cost match at least provided by search for their beneficiaries? That's something that we could, through a negotiated agreement, potentially pursue, Mayor.
Okay. Ms. Hale?
I don't think you have the answer to this question, but with the, if we were to close rainforest and then the nearest 3.5, whatever that means, facility is in Anchorage, how are they making it if we can't make it? I mean, who's subsidizing them? And maybe you don't have the answer to that question.
I don't have the answer. I'm sorry.
All right, Ms. Hughes Candies, did you have your hand up?
Thank you, Mayor. Yes, I just wanted to make a quick comment on the record. We love data. I love knowing that 40% of the patient population are CBJ residents. But as an assembly, we frequently are talking about what it means to be a good regional neighbor, and we bring that up anytime we do anything that's going to affect our neighbors. So I just want to be clear that we are aware that we are a regional hub, and we are aware that we take in the population of our neighbors, and it's good to know, but that is not something that makes me want to take any action.
Thank you, Ms. Hughes Candies. Mr. Smith?
Thank you, Madam Mayor. I guess just a process question, because I think it might affect the levels of questions that I ask. The goal or the outcome, desired outcome of this meeting is for the assembly to say, yes, we support the board recommendation, we choose a different option. Just help me on what we're being asked to do.
Okay, so this is the first time we've seen this recovery plan. So right now it's to ask questions on this and then just a general discussion. And if they need more direction in the future, we will have to give them direction. But I think hearing some of this stuff for the first time, I don't know if as a body we'll be prepared to give a ton of a direction. We might be, so we'll see how that discussion goes, but don't have any concrete plans on that, Mr. Smith.
Okay,
Ms. Hale.
thank you, that's helpful.
Thank you, Madam Mayor, and I probably should have asked this earlier, but when I look at the proposed timeline on page 3 of our packet, the final thing on it is that Bartlett Board of Directors on June 25th reviews and approves final recommendations. So does that mean that the Bartlett Board of Directors would approve the final recommendations to close some of these facilities without intervention by the Assembly before then?
Yeah, so I'm very glad you asked that question, Ms. Hale. And when where we're headed with this is a list of options. If you go down to the next slide there, Ms. McEwen. One more. One more.
Apologies, the internet has this lag
Oh, is
going,
that what
so
it is? Okay.
it's showing up on my screen,
Oh,
but
there we
now
go.
it's there.
So at the bottom in the options matrix, and I probably should have spent a little bit more time on this. So we have looked at all of these options as, if you think about broad options, are there areas that we could increase reimbursement? Are there areas that we could reduce costs or align costs? Is there a subsidy option that would be available, or is there close? And then the CHOW means that's an acronym for change of ownership. Could we find somebody else that would operate it, basically? And so the recommendations that we're going to be giving you, and let's use rainforest recovery as an option, are that the facility could close, or we would need a subsidy for doing that. So when you get and that's just as an example, I'm not saying that's what the recommendation is, but when you hear that from us, you will hear us kind of give you some options on the way that we could proceed with those. We're not going to be putting any stakes in the ground, I guess. We're not going to be saying, this is what we want to do. We're going to close this facility because, some of these things, you guys might decide that you want to subsidize it some way or another. Does that answer your question?
Ms. Hill?
Brief follow-up. So what you're saying is on June 25th, you're not going to be putting those stakes in the ground?
No,
Okay.
no stakes in the ground.
Thank you.
No, I think it's a culmination of a fact-finding process that we're going through here to try to say, to the best of our ability, here's what we think the range of options are. And some of these might have preferred options. We've only covered 1 of 6 so far. Some of them are a little bit more straightforward, and some of them are, much more complicated, like rainforest recovery is.
President?
No,
Ms.
So-
Johnston, did you have a question? Okay. And the board members can weigh in at any time. Just let me know.
Yeah, please do. ABA is the next one. We'll wait for your internet there, Ms. McKeon, but I'm on slide 7 of the.
Madam Mayor.
Mr. Smith?
Thank you. Sorry, I'm lagging too. Back to rainforest recovery. Maybe the CEO addressed it. I guess I'm looking at the line that just says max capacity potential. It shows in FY25, 2.861 million, which would exceed the operating costs, but is that just not achievable either due to staffing or reimbursement by Medicaid?
Yeah, just
Okay.
for clarity, that's a great question, Mr. Smith. For clarity, so the max capacity revenue number is $2.861 million. The actual collections and operating costs are based on the budget. So if you got to your max capacity on revenue, your operating costs are going to go up substantially. We haven't displayed max operating costs if you're at max revenue. So ABA, for the FY25 budget, the ABA had $461,000 of budgeted revenue. It has budgeted expenses of $1.1 million for a margin of $656,000. This budget document was developed in February, and a lot has happened on that. And we are actually at an option that we've identified for this that we think is going to result in the closure of this facility, or this activity, if you will, at the end of this fiscal year. So if you could go to the next slide there.
If I might, Madam Mayor, Mr. Merce, can you explain what the acronym ABA means for the record, please?
Yes, you bet. It's Applied Behavioral Analysis. And it's actually on the next slide. But yeah, so Applied Behavioral Analysis, but I'll do that for each of them as I go here, Ms. Beth. So ABA, let our slide catch up. Here we go. So ABA is, it's essentially support services for young children who are on the autism spectrum. And if I've misspoken, somebody over there that can correct me, this was a Juneau School District program until 2021, and in 2021, it was decided that it would move over to the hospital, and that's where it's been ever since. ABA has a limited amount of reimbursement. We're a fairly high-cost provider as costs are concerned. But under analysis, I think it probably makes the most sense to start with kind of where we are with this. ABA's 2 board-certified providers have given their resignation that's effective June 13th. And and they've notified us that they want to go into private practice with this program. So we're in a position now where we will support them in that transition to private practice, and this will cease to be a Bartlett-provided program going into the next fiscal year. So that's, you know, kind of a change from when we did our budget on this.
Mr. President.
I just want to point out that this is a really great outcome for this program that is much needed for our community again, you know, for children that are suffering on the spectrum. It's needed. It's a one-on-one program. And for the clinicians that are resigning and are going to be opening up their own practice, this service is going to be provided for our community. And this is like a very good outcome. This is exactly what we'd like to see, just us kind of partnering with them. And Bartlett, like Max and Mr. Mertz said, and Mr. Warden's actually told us too, is that we, as our hospital, are going to be really supporting this program going forward with these new services that are being provided by other people in our community.
Ms. Hughes Candies.
Thank you, Madam Mayor. Just one question. Was wondering what support entailed from Bartlett.
Ian.
Talk to them about how do we help them find some space. There's equipment that's part of their offices that we could sell to them very low amounts, as well as anything we need to do to make sure that patients are notified, patients are moved over to their extent. But we, you know, the billing system can go with them too, things of that nature.
Mr. Smith.
Thank you, Madam Mayor. Maybe not super necessary as maybe is already happening, but I guess my question is, in this transition, what any expected impacts on families? Like, is the capacity going to be the same? Will costs to families be the same depending on insurance levels? Type of insurance, excuse me.
Mr. Smith, I don't have that. Do you?
No, I don't.
I don't have those answers. Kenny, Kim, does anybody else have those answers? We can get those for you. We'll note that and get you an answer on that. As to whether it's seamless, I think is your question to the recipients of the services or not. Yeah. Okay.
Maybe we need to rent them space and charge rent. Just coming up with some revenue for you. Carry on, Mr. Mertz.
Thank you. So, Ms. McEwen, if you could move on to the next slide. So, crisis is, for the record, what we're talking about is crisis observation services, which are kind of more of an outpatient, if you will, and the residential services, which are more of an inpatient type of service. So you'll hear me use the acronym COS, and you'll see it in your packet, and CCS. COS is Crisis Observation Services. CRS is Residential Stabilization Services. This is the new building that we have at Bartlett. So there were some revenue bonds that you guys approved, I think, in 21, and we built a $60 million facility around this. And the budget for crisis combined, both components of that for FY25 are revenues at $2 million, expense of $3.2 million with a loss of $1.2 million. That's the budget. If you would go to the next slide. So I actually asked Mr. Warner to include this because the budget doesn't paint the whole picture. The budget is based on a pro forma I'll be talking about a little bit more here in just a minute. But we're expecting now, you can see the word estimate in there for FY '25. We're now estimating that we're gonna have revenues of $2 million, revenues of 960,000. So instead of 2 million, revenue of 960, so about half the revenue. Expenses pretty darn close to what we originally forecasted in the budget, down by about 100,000 due to some cost savings we pursued. So a net loss of $2.2 million. And it's important to, as eye-popping as that is, it's important to understand what's not in that number. And what's not in that number is debt service on the building. So the principal and interest on the bonds is not part of that number. And there's no overhead in that number either. There's no cost related to just the general support that Crisis gets from the hospital as a whole. So those are direct revenue and expenses. And I'm pointing that out just because, just to make sure it's clear that the $3.1 million that you see there are the direct expenses of providing those services.
Could you pause for a second? Ms. Johnston?
I just wanted to point out that the packet has 2 copies of this page. So what Max has been speaking about is the following page. It might be a little more helpful to follow what he's talking about.
Yeah, the next one, yeah, that page right there. Yeah, that's the second page. Yeah, you're on the second.
This is the first page, and then we move to the second, and they do look very identical, except for there's a few number differences there.
That's exactly right. It is a little confusing. So it's the more, and there's a little bit more detail in that. Here, we're going to move you again, Ms. McEwen, but if we go to the next slide, please. So Crisis Now, I think everybody's familiar with the Crisis Now model and the focus and the efforts that have gone into that over the last 3 or 4 years. And when there was a pro forma done on that facility, there was pro formas there was a couple of pro formas. There was one that was done and I think it was around fall of 22, Kim, I want to say, in that ballpark, pre-opening. And that's the pro forma numbers that you see here. Before that, there was some analysis that was done. I'm not sure pro forma is the right word, but in the decision-making process that was done by management and then the board, there were some assumptions that were used around revenue and expenses that are not presented here because they have proven to be inaccurate. And there was some follow-on work that was done to try to determine what would be more accurate revenues and expenses for that facility. And that's the pro forma that you have here. And I know they're small, and Ms. McEwen, is it possible to make that a little bigger on the graph or no? Are you locked onto the size? That's great, right there, perfect. So the 24, remember, we just really kind of started operating this during FY '24. We had a pro forma of about $577,000 loss. We're going to incur about $1 million loss in '24. In '25, again, another pro forma of $582,000, and we're going to have a $2.1 million loss. That compares to the budget of $1.194 million loss, and I'm on the bottom lines there. Okay, so it's important when you look at the numbers that there's not a lot of variability in terms of the total expenses between the pro forma and the estimate. There's, it's a little bit higher on the estimate, and the estimate and the budget are very close. So the second gray bar there, the total expenses between FY '25 estimate and budget are pretty darn close, 3.1 versus 3.2 million. But if you go up the page, you'll see that there's a significant difference in the revenue. And even within the components of revenue, there's big differences there. So for FY '25, we're forecasting, we budgeted that we'd have $1.9 million of revenue. We had a pro forma that said a little bit more than that at $2 million. And then the estimate that we've come up with now that is based on what we're seeing is in the market is $960,000, substantially lower. And if you look on the components of revenue, Medicaid revenue versus other insurance revenue, we get paid a much better rate for the other insurance, and actually our incidence level has been much higher on the other insurance revenue than it has Medicaid. But even on a combined basis, those are less than half of what the pro forma was thinking was going to be. And there's a realization there that we've been coming to that is kind of difficult to wrap your head around. But the fact of the matter is, when the pro forma was done, it had an estimate of that there was some national statistics out there around how much, based on population, how many beds that you would expect to fill and how many observation beds you would expect to fill. And they took those numbers as averages and multiplied them by 1.5. So they were estimating 150% of the national average for revenue. And as we're getting into it, we're seeing the operations, at least so far, what we're seeing is actually less than the national average. So the pro forma is just not, is not bearing fruit, if you will. We're not seeing that. And so that revenue, now, there's a question that could be asked, well, what about 2 years from now? What about 3 years from now? What if we continue to operate that? Is that something that, and that's an important question to ask because, potentially yes. I don't think that, nobody has a crystal ball, and if we're looking at 28 or 29, could it be a different circumstance than it is now? Because it is a brand new program. There's some additional funding that was disapproved by the legislature around this. We don't have the time to figure that out, unfortunately. So we're at a $2.1 million loss for the year, and the hospital can continue to incur that. And that's kind of where we're seeing this overall.
Ms. Hughes-Candies?
Thank you, Madam Mayor. I have two questions, but I'll just do one so Ms. Wall can jump in. I'm looking at the operating expenses, and I appreciate having them broken out the way they are. And I guess what I'm wondering is, looking at the numbers that you have, the occupancy that you have now, this is a somewhat silly question because I know there's a tremendous amount of effort going towards making things profitable. But is this a sort of program that you could scale back, or are you already operating? You could not reduce your operating expenses.
That is an excellent question, and it's a fair question. And we have asked that question, and actually the second bullet point addresses that under analysis, and I probably could have spent a little bit more time on that, but staffing levels currently at minimal staffing levels and are mostly contract labor. So we're kind of already at that skinny point. I don't know, Kim, if you wanted it, is that covered? Yeah. So basically we're operating this as thin as we possibly can right now, getting back to the comment about, squeeze as much as you possibly can. There's operational issues inside the facility, and Mr. Johnson during his public comment talked about that. And we can delve into that if you'd like. I'm not sure it's necessarily a good use of the time today, but they are finding that there are operational difficulties because of the layout of the facility, believe it or not. Even though it's brand new and designed, there's just the layout of itself doesn't allow for some of the uses that were originally conceived of in that facility. And so what we have is a $60 million building that's housing a facility or an activity that's losing $2.1 million in direct costs. And it's an unfortunate circumstances we're in. Is there a silver lining to this? If you're receiving services from that, not a lot. There are services that the hospital is currently hoping to provide that an analysis of that building and the footprint of that building potentially could identify other uses that would be good for the hospital, that, would give us, some things that we're not able to do now, that would need to, if we decided to close the facility, that we would have to go through, orthopedic surgery. There's different things that you could look at that you'd potentially be able to put in there. Some of them would require capital costs, some of them wouldn't. And so, this one it's a tough one. And, you know, it's nevertheless, it is what
Ms.
it
Wall
is.
has a question, so let's go to her.
Thank you, Madam Mayor. Super helpful. One of the things that's not addressed here is, you know, you mentioned kind of volume being lower than average. Are there other services in our community that are similar to this, or is this like, is part of the volume reduction because people are going elsewhere, or no?
Kim will correct me if I'm wrong, but I'm pretty sure we're the crisis now provider in town. So there is no other services here in town.
Have we,
providers.
I asked her question a little bit different. Have we figured out why the volume is so low then if we're the only service?
Kim, you want to come up?
Kim McDowell, Chief Operating Officer at Bartlett. That's a great question. We're not sure. We do know that there's opportunity throughout the state that people, other agencies want to send adolescents to us. The problem is that, or the constraint we come up against is that we are a 7-day residential on the residential side. And a lot of the adolescents that need to be sent to us will require like a 4 to 6 week stay. And that doesn't fit in within our model of the building currently.
All right, thank you. Ms. Hughes Candies?
Thanks, Madam Mayor. I think Ms. McDowell just started to touch on the heart of my question. So we are looking, because, you know, it's ADN articles about how kids are getting institutionalized because they don't have enough adolescent services within the state. So I guess I'll ask, if we are not designed for that 4 to 6 weeks, could we make adjustments to this if there's this overwhelming demand within the state of Alaska?
Ms. McDowell?
Thank you for that. So there's always adjustments that can be made. I guess it depends on the amount of dollars you want to turn into that for that program. Currently, the crisis adolescents unit that we have, it's a delayed egress, so it is not a locked unit. So therefore, we have certain criteria of adolescents that we can't accept. So if they're acutely suicidal and at a really high risk for themselves, they're not appropriate for that facility, for that area, because they can't. It's not locked. It's strictly a volunteer service.
And if I could just follow up, Kim, and it would require pretty significant redesign of the building in order to allow for that, correct?
Yeah, that is correct. And currently, we're still waiting for state regs to come out, which provides a challenge with making any changes. But currently, the regs that we are kind of loosely following with the guidance from the state would, are, like I said, from a delayed egress, a voluntary standpoint. And in order to make it a higher level to serve higher acuity adolescents, they would need some significant changes to the design plan.
Thank you. So to summarize this one, kind of where we find ourselves in is, if we want to continue to see if there's other options, it's going to require a subsidy, or we're going to have to choose to stop operating that program and look for potentially other uses of the building that qualify for the revenue bonds. If we choose to continue it as we are now, it's also going to require probably a reevaluation of what services we're providing in there and whether the capital costs. And honestly, it's a good money after bad. I mean, at what point, that's the question you have to ask. They're hard start questions, and but it's a question you have to ask: is, do we want to continue to pursue this? And if we do, we're probably looking at dollars to make that happen. In the meantime, we have to have a subsidy to keep it operating.
Mr. President, then Ms. Hale.
Again, I think that this is really important. Again, I think this is really important. What Mr. Mertz is saying is that we really want to hear from what the public has to say on what they want their community hospital to look like.
Yeah, absolutely.
Thank you for that. Ms. Hale.
Thank you, Madam Mayor, and thank you for that comment, Mr. Solomon Gross. I was the liaison to the board when this was being envisioned and was privy to a lot of the conversations about it. And there was a lot of concern, not just by board members, but by community members, that when kids were in mental health crisis in our city, they had to be sent down south. And that was so destructive to the kids and to their families, and a lot of the families just never recovered from that. So it's a really, really tough question, and I think it really is a question for our community. Just as a question of, do we subsidize facilities like rainforest recovery, meaning that we're also subsidizing facilities for other people in Southeast Alaska? It's really a question for the community, because that is hard on families.
I just have a question on, it says 24 encounters since December of 2023. Is that the only metric we have, or is it because it's so new it doesn't have anything for the year before?
Yeah, we just started operating it there.
Okay.
Madam Mayor, too, Mr. McDowell, can you tell us the 24 encounters, how many of them are repeat?
Thank you for that. As of, since the opening of the program, we've had 37 visits, and some of those are repeats, so I would say probably have 24 of those, and then the rest are repeat adolescents coming in for services.
Are we done with this particular section? Okay, so we've been here for a little bit, so let's take a break, and let's come back at 7:20. Ms. Wall.
I appreciate the break. I just wanted to say, it seems like tonight's going to be a long night. I hope people stick with us. But in case not everyone can, just wanted to say, with all due respect to all the amazing work that went into these graphics, because this is super helpful for me. It is relatively easy to do this compared with getting up here and putting a human face to these issues. So just wanted to thank our testifiers for being here.
Thank you. So we'll take a break to come back at 7:20.
I just helped myself.
We will bring our joint meeting back in session. Mr. Mertz,
Yes.
next item.
Yes, thank you. If we could go back to, if we go down to the next slide, Mr. Barr. Here we go. BOPS, and that's Bartlett Outpatient Psychiatric Services, BOPS. BOPS, and I'll talk a little bit more about what it is, but BOPS has $1 million in revenue forecasted for the current fiscal year, coming fiscal year, expenses of $3.8 million for a loss of $2.8 million. I want to.
Madam Mayor, we are struggling with technology, the internet. We had an undersea cable damage today, so I think we're going to have to rely on our packets.
Oh, all right. Do the members online have the packets, or do we need to be taking pictures? Okay, good. Okay, carry on.
Okay.
Everybody has packets, hopefully.
I am on numbered page 11 of the slides. And I want to focus on the options matrix here, because you'll see that this one is unique from the others in that we're really focused in on reducing cost and realigning this program. And so that's kind of the direction. I think you'll hear us in a final recommendation. It's a little bit, to Ms. Hale's point earlier, it's a little bit, the path is a little bit more laid out for us, similar to ABA on this program. If we could go to page 12 of the slides. The behavioral outpatient psychiatric services has been in place at the hospital since the 1990s. And it's an outgrowth of the mental health services, the inpatient mental health services that the hospital provides. So the the idea is that you have a so I'm on the next page there when you get to it, Ms. McKinn. So the idea is that you have this staff that is in place that is serving the the inpatient mental health unit, and they have excess capacity. And so we're going to take that excess capacity and we're going to provide behavioral outpatient services with that excess capacity. And that's kind of what has been the intent since the 90s. And frankly, it worked very well up until COVID. And I'm moving over to the chart and I see that we have it up now. And I'm in the chart that's under pro forma analysis because, man, this is an important one for us all to understand. And there's some stark things that really point out here. And I want to start with the FTE line, and that stands for full-time equivalents. This is the number of staff that we have in there. And look at 2019 at 5.41, and then look at 2020 at 11.67. So and then in 21, it went to 13.63, 22, it went to 15.93. That's COVID. So what happened was we had this need to provide these outpatient psychiatric services, and we couldn't provide inpatient services. And combine that with the fact, as I was referring to earlier, we had these provider relief fund monies that were designed to provide hospitals with the cost to be able to do these things. And so the hospital geared up and really changed, if you will, the services that they were. So we went from an inpatient mental health model to an outpatient psychiatric service model in basically a few months in 2020. And that was a huge, and we're still kind of left with that. And as you scan across, and I'm on the top line on that FTE line on the chart, you'll see that after 2022, those numbers have started to come down. And I've got some updates for you based on some, just the really more recent information. So in 2024 now, that 12.71 is now 12.4. We're 12.4 FTEs, that's as of today. So, and then we're expecting in 2025 that we'll probably be under 10 by the time we get to the end of the fiscal year. And so what you're seeing is, and this is a lot of work in a couple of sentences, a lot of work by staff that have gone into realigning those services to allow us to return to the inpatient mental health paradigm that we had pre-COVID. And so that's the direction that we're going with. There's no subsidy we're looking for here. There are no changes that we're looking for here. This will very much become part of the overall improvement model and for the hospital. And the kind of the best part about what we're seeing here is the flip side of this is that our average daily census at the mental health unit, which was it was at 2. We were stuck at 12 beds. We were stuck at 2 or 3 for months and months. We'd make a little bit of improvement. We had some problems with staffing, attracting and getting psychiatrists in there, and they'd come back down. It's starting to stabilize. And last night, Ms. McDowell reported to us that we were at 10 ADC, average daily census. So 10 of the 12 beds, which is a pre-pandemic census for that. So we're making great strides. That work is paying off. And that also, again, we're here talking about finances. So even though there's a lot of humans that are involved in this, it's important for us to point out the fact that we're talking about $5,000 a day of reimbursement because those are very expensive services. And so the fact that we're able to do that has a really good, means really great things. And so when you look at the FY25 budget, you'll see over on the right, and it's back up on the screen, we had $2.1 million of revenue or charges, if you will, $2,112,000. This is for the budget, and $3,865,000 in expenses. That was made on, and so that net is $1,753,000. If you do the same math on 2024, it was $3,091,000. So we're going from a $3,091,000 loss to $1,753,000 in BOPS. And at the same time, what's not present here is the increase that we have in inpatient mental health revenue. And those numbers are changing. The 25 numbers are changing as management continues to do good work. Correcting isn't the right word, but just getting out of where we were with COVID back to, the way this thing was built to work. So our hope is, and essentially what you see in our recommendation for this, which will be we'll continue to manage this as a core service as part of the mental health. these changes are within management's purview. We're not looking to the assembly for any sort of subsidy at this point on this. It's continued good work. So when you combine that with, we have some good news on ABA certainly, and we have some good news here that we're kind of pointed in the right direction. So any questions on that, Mayor?
So if you combine this with the in-house mental health care, does that help with the administration spread out over several programs then, or?
Well, we're
Or
going to
not
have,
really?
yeah, so from a cost report standpoint, this unit, if you will, this service, this mental health services will forever get a piece of that overhead. There's an allocation that the cost report preparers have to go through for that, and it will be there no matter what. So it's not going to go away. It'll be there if we're under critical access. It'll be there permanently. Does that answer?
Yep.
Okay.
Any further questions? Give you a break and you guys all
That was
sleep.
easy, yeah. So if we could go down to the last couple of areas that we're going to be looking at, and then I'll wrap up. And we're going to spend some time here, though, and that's home health and hospice, and they're boxed together for a reason. You have leverage staff here, so there's staff in hospice and home care that wear both hats. Some days they're providing home health services, and some days they're providing hospice services. And I think it's clear when we talk about hospice, what we mean about hospice. Dr. Urata did a good job defining that for us, actually, in his public comments. And home health is a suite of services that are provided by the hospital to people in their home, as it sounds. Not necessarily to geriatric, though commonly geriatric older patients, but it can also be people that are in rehab that need some sort of additional services in their house for various stuff. So when you think of home health, just think of a provider of mid-level or some sort of provider that's going into somebody's home and doing something, and we get paid an encounter rate for that, for providing those services. So, and I'm going to walk back a little bit through history here because I think it's important. So hospice and home care was provided by a nonprofit in Juneau starting in the 1980s called Hospice and Home Care of Juneau. And Dr. Urata was very much a big part of that, that entity. Hospice and home care was paid under basically kind of a feast for service model. You go out and you do your work, and you fill out your little note and you bill that and you get it paid. And then Medicare, in their infinite wisdom, in the late 90s, changed the billing model to something that only, I don't know how they came up with this, but it's this incidence period where you have to prove the patient and the acuity level over a period of time. And it made two things happen. Number one, it made it very cumbersome. Home health billing, if Joe was here, one of our billers would tell you it's the most cumbersome thing. It takes a lot of time for those, and it's very disparate. It's very different from billing for, somebody that's in your acute care. It's just a whole different animal. There's different billing systems that are built around this, and the time that management has taken to gear up for us to be able to build this is impressive, and for them to have been done to do that in a period of time. So going back to what happened in the 90s, the other thing that happened was the reimbursement also went down. I mean, they did this because they wanted to reduce the amount of money that they were spending on home health. And I keep looking to my left. I'm glad to see Dr. Urata nodding his head because I know I'm on the right track here. And so about the same time, I think it's important to have, because I want to weave into this, hospice is partial revenue. So we're going to be talking a little bit about both of them together. A lady by the name of Verna Kerrigan died, and Verna Kerrigan left money to Hospice and Home Care of Juneau. Richie Saunder was the executive director at the time. Many of y'all will know Richie. And she left several $100,000 to Hospice and Home Care. And it was with the intent that it support their services. And a couple of things happened during that period of time. The state of Alaska, for one, started looking at the balance sheets and the financial statements of these nonprofit organizations and said, you've got all this money, we're going to pay you less because you've got all this extra cash. And so the way that you dealt with that is you took the money and you pulled it off the balance sheet and you put it in a separate entity so that you didn't have to report it in the entity that was doing all these operations over here. And then so many people were doing that across the country for a variety of different stuff, from booster clubs, all kinds of things. The accounting rules changed and said if you've got one entity that exists to support another entity, you got to combine those two. You got to put the two entities together. It gets back to Enron. There's all kinds of excitement that went along with that. So, long story short, because of the fact that they had a common board, this entity had to fold back into the financial statements, and we're kind of left back with having to support, prove that we needed that money. So one of the big tests is, do you have a common board? And if there's a common board between the two entities, then you have to combine them. If you separate the boards, if they have two different boards, then you could have you could design it in such a way that you didn't have to consolidate the entities and put them together. And so we did that. There was an accountant in town that helped them do that. And so they set up a separate board, and that separate board had their own kind of minds over time about how they wanted to spend that money. And then when CCS, Hospice and Home Care, 2 or 3 years later went out of business, they took that, they took the program, they essentially gave it to CCS. Rosemary Hegevig was the executive director, and it would not be here today if it not for Rosemary Hegevig. And so she took that over, but what was called at the time still Hospice and Home Care Foundation Board did not want to give that money to CCS. They wanted to continue to maintain it. In fact, they changed their name to the Foundation for End-of-Life Care, and we actually have one of their board members here with us. And they've been operating that and basically operating this function of trying to raise money in a very admirable way for hospice services ever since 2005, 2004, somewhere in that ballpark. I think, Al, is that about right? So that money that was, when it went from the hands of Hospice and Home Care, the board made the decision, and as a matter of fact, it was one of the first third-party donations to Juneau Community Foundations. That money is sitting actually in JCF. And it's still there, and it's earning interest, and it's available for these services. And they have a spending plan at JCF that money then becomes donation money. And I'm coming all the way back around because it's very important when you think about hospice. The hospice side of this thing is that hospice entities typically have a lot of community support. These things are, they're strongly supported in their communities. They're typically a nonprofit. They operate typically on a shoestring. It is unusual actually to see hospitals operating hospices. I'm not aware of a lot of the models. Maybe Dr. Rod is more familiar, but normally it's a mom and pop operation or it's a nonprofit that operates that.
Was that a question for me?
Sure.
Can I answer?
You got it.
Yeah. So, my name is Bob Urado. So many cities have home care with hospice associated with it.
Do they? Okay. So nevertheless, there is and you'll see on the hospice piece, and I'll get into the individual kind of pages. I don't want to go down there yet, but part of the evaluation that needs to be done when you think about hospice and home care is the ability for third-party revenue to be brought in, donation revenue to be brought in to help support that. I am a big believer in the fact that for those things to come to pass, you've got to have stability in organization. I mean, organizations that have strong support in a community, think about the Aware Shelter here in Juneau is a great example. They've been around for a long time. They do really good work. People get used to seeing them. And when things bounce around and they change a lot, you kind of lose your donor base. And I think that there's a donor base to be repopulated, if you will, for hospice that is, that's really not included in here, and there's a reason for that. So I want to go back up and look at this, and thank you for bearing with me on this. But we are expecting for the full FY25 that home health will lose $934,000 and hospice will lose $448,000 or combined $1.3 million. So, the revenues the expenses are far in excess of revenues. If Ms. McEwen, if you'd go to the next slide. So home health, and there's a couple of things I want to point out for those of y'all who have read through the packet. I won't spend a lot of time in the detail in here, other than under current conditions, under number 3, when this was written, the director of the program of the home health. So the way the organizational structure works there is Kim Stout is the head of that program. Kim Stout also oversees wildfire court for the hospital. And under Kim Stout were 2 directors, and 1 home health and 1 hospice. The home health director quit. And rather than rehire for that position, they recently made the decision to have the hospice director oversee both of those. So 1 person is now overseeing, and that's both the cost saving measure as well as, just she's very good, my understanding. The other thing I want to point out, because it's a little confusing on this slide, is that all the statistics, so remember, we really started operating this in July. There's a demonstration period. We are still yet to bill $1. Is that right? We have not yet billed for these services yet. So we have charges that we're incurring that we can bill for when we're allowed to. Is that right, Kim? That's correct. So there's a period of time where you have to go through a certification where they come in and they do an evaluation of the program, make sure that you've got all the things in place that you have to have in order to operate the program. And it's not until you get that certification that you actually can start billing. We've been going through that program. We expect to start billing that very soon. And so we're dealing with a very kind of nascent population set for hospice and home care that really doesn't even include billing for a program that I think we all understand intuitively in this community how important it is. I mean, I think to a person, when you think about hospice and home care, you're just like, okay, we've got to have a good landing spot on this. So the other point thing I want to highlight here is number 9 on the current conditions. There may be, and may is with capital letters, there may be a third-party option for hospice and home care yet. And we haven't done our due diligence, and there's significant due diligence that has to happen on that. There's potentially a provider in Anchorage that's been interested in coming down here. We haven't had a chance. We haven't had a chance to yet talk to them. And so one of the things that we need to evaluate for hospice and home care is whether there's a third-party landing spot. Due diligence, I think, is there's a due diligence checklist that you think about when you're doing a potential offloading of that onto a third party that would have to include, rock solid feeling that, they're going to be around for a long period of time, and what assurance do we have for that? And then also very close analysis of, is the community of hospice consumers, if you will, and home health consumers in Juneau better served by having that inside our community hospital or outside the community hospital? And that's part of what we want. That's part of what the next month is so important about is hearing people's input that we'll be listening to very closely. So is there?
Ms. Hale.
Mr. Mertz, thank you for that historical romp there. That was really helpful, actually. And this might be a question for Dr. Urata. I appreciate what you're saying about a community entity, for example, board, for example, being responsible for hospice and home care because it is so community-based. Do we know why it was turned over to CCS when that happened? I mean, what happened to that group of community members that it folded?
Well, I think I know the answer, and if I'm wrong, I'm sure Dr. Urata. Hospice and home care was operated by a director and a part-time billing person. And when they implemented the more complex billing model, that made it almost impossible for them to do billing. I mean, it was literally that stark. I mean, they literally couldn't generate revenue. And they actually burned through some of the Verna Kerrigan money, keeping their head above water. And the end game was clear that hospice and home care as a standalone nonprofit couldn't survive. Catholic Community Services, and again, at the will of Rosemary Hagevig, saw how important that program was. And at the time, CCS was a very vibrant, strong, operating a lot of different grant programs that were in our vital to Southeast. And there was, had also some additional federal support that they lost later. And so that base allowed them to I don't know if carry is the right word, but that's really what it was. They basically carried hospice and home care for a number of years until the CCS revenue stream kind of dried up and suddenly they couldn't manage it anymore. And that's where they were left with their own kind of stark choices. Does that sound about right? Thank you.
Ms. Hughes-Ganis.
Thank you, Madam Mayor. Thank you for that history. That is helpful. My question might be potentially one for Mr. Warden. I think you're absolutely right. There's an intuitive sense from the community. Until Bartlett took it on, people were kind of horrified at the idea of not having hospice. And I understand the link now, thanks to the history of the home care and hospice. And when we do this great public input, then we'll find out if people feel as passionately about home health. But Mr. Warren, could you speak to if the two things are married, do you see a future where we either figure out that yes, we need this as a community, or we turn this over when we do a little more due diligence? When we talked in advance of that finance meeting, it really seemed like the billing model for home health really was only designed to work in a place like New York City or a way less linear town than ours.
My experience at home health, and I've had experience in hospice. I'll deal with hospice because it's easier. Hospice tends to, the reimbursement favors longer time in hospice, 6 months. We have a very short time frame, 28 days in hospice. So if we can get the length of stay, if the population would use that service earlier. So we have the Jimmy Carter versus Rosalind Carter issue. You know, Jimmy's been in there for a year and Rosalind was only in there a week. So the reimbursement favors the year, not the week. Having said that, on home health, in the two places that we've had it, I've never seen it to be profitable for a couple of reasons. First of all, the payment mechanisms where you do see it more profitable is lower cost on benefits, lower cost in terms of salaries. You tend to pay on a per visit basis, not a salary basis. In Seattle, when we looked at that, that's just not acceptable to the union, so we couldn't do anything. We then moved out of it. What they tried to do, and I think this was smart, is see if we could combine the costs of both of them so that we could share the costs. They're sharing space. When they're not busy on home health, you're moving over to hospice and vice versa. So that was anticipated that you might break even or do a little bit better on home health, but hospice would be more profitable in the long run. We're not seeing that. And I think a lot of it is just because of the way people view hospice at this point in time in this community. And that is they see it as the last resort and they're giving up. And that's just not the type. I don't know if you've seen that in your practice, doctor, but so I think it was smart. Now, having two managers or directors in there versus one was a cost that I don't think was necessary because you need one person managing across both if you're sharing staff and scheduling and things of that nature. So I thought it was a good move by the group that made those decisions. I think that was Kim and her staff. So I think it's the right move.
Go ahead, follow up, Ms. Hughes-Ganis.
Thanks for that. Follow up, not a follow up, but just another quick question. They're leasing the space currently. Could you just speak to that really quick? I was surprised to see that.
Mike.
Thank you. We have a lease that's $2,600 a month. We're looking to provide a termination of that lease and find space where we don't have to have a cash outlay for that. That would be somewhere around 26 plus 5, 2, so $31,500 of savings. So.
Ms. Wall, did you have something? No. Okay. Anybody else? Okay.
So, that, just some closing comments on hospice and home care, and then just to kind of wrap up a couple of things. We're still left with the stark reality of where we are, and, you know, we're interested, I guess we're very open-minded about this program in terms of, you know, how to move forward with it in such a way that it protects the program. I think that's number one. You know, getting back to what Kenny's comments, Mr. Solomon Gross's comments were at the beginning of the meeting, that, you know, we're in this together. We look at this as kind of a team thing. We're here to serve the community, and we want to do what's best for community. And part of that is is keeping a strong independent hospital. And to do that, we've got to have, provide those services that the community needs, but we've got to also be able to pay the bills too. And I got on the board not 2 years ago, and we have gone, and it was right at the tail end of COVID, and these losses started. We were looking at, first thing I did was look back at the 3 months of losses that we had prior to June, March, April, and May of 22, and I almost fell out of my chair, honestly. And we have gone from 160 days of cash, 160 days of revenue in cash, to 70 in not 2 years, in 2 years' time. And we don't have the time. The metric that hospitals should strive for, according to, the national rating agencies, is around 160 to 180 days. And the reason for that is you've got to have reserves. You've got to have a cushion to fall back on. So we're already into that desperately. And we can't once you hit about 30 days in reserve, you're having to stretch payables. I mean, we're literally getting down to that point. So we don't have, we don't have time to kick the can down the road. We just don't have that time. We have to make some stark, hard choices about what we're going to do about these programs and turn this ship around in a hurry. Or we're in a year from now, even it'll look a lot more different. When I said we had 3 years of cash, that's to drive it to zero, but you run out of cash before you run out of cash. You run out, you're not able to operate anymore. So I'm just, I would just advise people to understand that we really need to make some hard choices about these things. So that concludes what I had to say.
Mr. Cone, sorry.
Well, Mr. Mertz has talked about pre-COVID and post-COVID and how the finances have changed. I just want to put a little bit of context around it. And the context is that in the lower 48, since COVID, about 125 or more hospitals a year are closing. They're out of money. They've the same problem. We're dealing with that problem. The difference is that if you're in Oklahoma and you close your community hospital and you're 100 miles from whatever, a big, hospital group, you can take an ambulance, you can take a helicopter, whatever. You know where we live. It's not. We're in the same. We're dealing with many of the same problems as these community hospitals that are closing left and right down there, and we have no out. Thank you.
Thank you for that comment, that nice refreshing comment. But needed. Ms. Peterson.
Sorry. I grew up in a little tiny town in Ohio, and I know none of you have ever heard of it. I would be shocked if you had. However, there is a hospital, a small hospital about 10 miles away that literally closed its doors last week with a 5-day notice. And like Mr. Khan said, of course, there's big hospital systems around. People can drive 20 miles, 20, 30 miles and go somewhere else. But the reality is that all emotion aside, we all love and care about these programs. But we have to make some tough decisions. And it's not that any of us want to close anything, but we need help finding financial assistance. The hospital has taken, and I'm going to say even the city because, we're part of the city, we have accepted the financial responsibilities of providing all these programs, and we don't have any money. And so in order to continue the programs that we have and to provide the services that we all think that we all love and want, we have to come up with some ways to figure out how to pay for them. And it's not just us. I mean, it's our whole community, the school system and everything. So it's tough times, and I believe we can solve it, but we have to be realistic. Thank you.
Yep. Mr. Cohen?
Again, just briefly, but I've been in Juneau since the early 80s, and I remember what happened in the mid 80s when everyone from the state that we knew were laid off, and we had what 400 to 600 houses for sale or something, and so if we're talking about supporting the hospital possibly with property tax or something like that, I know nobody wants property taxes to go up, but I mean, then think about it this way. We're talking about 600 or 700 jobs, good jobs in this community. We didn't lose 600 or 700 jobs when the state laid off those people, a lot less than that in Juneau. And Juneau tanked. And the only thing it'll solve if this hospital goes belly up is your housing crisis, because you'll have lots of housing and you'll have no base for your property tax rate, because that's going to nosedive too. This is crucial. I think this hospital is crucial to this city. And we've seen this happen before. We saw this happen 35, 40 years ago. It can't happen again. It took us, what, 10, 15 years to recover from it? Okay, thank you.
Mr. Smith, did you have your hand up?
Thank you, Madam Mayor. I guess, just for myself and the public, looking at the schedule, we can see in June 25th, the Bartlett Board of Directors will review and approve final recommendations. I guess I'm just kind of curious to know, like, what then? I mean, is there going to be time to do that due diligence on home health and hospice by then? I guess, will there be another joint meeting, or I'm just curious, will we say we'd like to subsidize rainforest recovery and 5 of us vote to do that and, try to come up with the funds? I just want to know what that feedback loop is, I guess.
That's a good question. Don't have the answer to that one tonight. But your mic.
Yeah, it's a good question, Mr. Smith, and we are continuing to gather the information as we go. We'll know a lot more about some of these things than we know today. We knew a lot more, we know now than we did a month ago, and so we won't have it all done, but we will have a lot better basis for some of these things than we do today. But we do need to have a pretty good understanding of, what the will of the body is. I mean, I can tell you how my opinion on some of these things as a board and the way to go, and we'll gather some more information and see how that looks then. And then at that point, you'll have your slate of options, and then, we're off and running, if you will, on carrying those out. So.
Mr. President, do you have something to add?
Just to answer that maybe a little bit more too, is the way that we kind of laid this out to make sure that we had input from everybody. I think part of today's meeting for us is to lay this out for the assembly and get your guys' input and what would you like us to do. We'll have some decisions or partial decisions, send them forward to you, and have maybe possibly another joint meeting to discuss where we go next. What's our next step? So that's kind of, right now, I really feel that this is mostly giving information and getting feedback. So I believe that's where we're at right now.
So just looking at your chart, I don't see anybody else's hand. So rainforest recovery, would need 782,000. I'm ignoring the hospital piece right now. ABA, you guys seem to have a solution from that, so we don't need to look for money for that. The crisis center would need 1.2 million. BOPS, it sounds like you can reorganize there, so we don't have to worry about money there. And home health and hospice are at 934,000 and 448,000. So if I did my math right, that's about 3.4 million we would have to come up.
So
I'm just making sure I understand things.
the crisis center is the budget number, so the number you really should be using for crisis is off page 9. So instead of the 1.2 million, it should be the $2.2 million extra. So just add $1 million to.
Just add $1 million, you said.
Yeah.
Okay,
Yeah.
So we would usually come up with about 4.4 million roughly. So, interesting time since we're just passing our budget, but that's all right.
Could and I don't want to complicate it, but I'm going to complicate it a little bit. So when we're talking about, especially as it relates to critical access, when you know, more full analysis, you're reducing the reimbursement of what could be used to help support the core hospital. So, and by material amount, I mean, you could be offsetting that by $1 million or $2 million just in crisis, because you also have the debt service that you're covering, you have overhead costs that you're covering. So instead of taking the oomph out of critical access, which right now kind of the functional number we're using is around $5.8 million, that could be 3 million or 4 million. So what it does is it increases what we'd have to have in order to pay for these other programs.
Okay. Ms. Hale?
Mr. Mertz, that made 0 sense to me, and I actually don't know that I want you to make that make sense to me. Because I just don't think that without a whiteboard and 15 minutes, it's gonna help. Thank you.
All right, so, anyway, I just was trying to, I understand what you're saying, not quite exactly what you said, but, if we keep the programs, it makes the admin, cost more spread out, so it takes away from the hospital. Got that. I don't want your detail either. So the question is those other programs, and my personal opinion, because I haven't seen anything here, I'll have to say the home health and hospice, I don't think you're quite there yet, because you just got it, and it seems to be doing better than expected, so I'd almost let that play out a little bit. But that's just my personal opinion. And on the other, you know, rainforest recovery's been around a long time. I know it's not a moneymaker, but it seems to me the community might want to support that. The crisis center, I know there's a need for that too, but that's a harder one to justify. But again, that's a new program, so it's tough. So we have some tough stuff ahead, and you guys certainly have tough decisions to make too, so. But I'm not looking for anybody to, I mean, if they want to weigh in, that's fine, but seems to me there's still some stuff that needs to play out, especially hearing from the public and see what they're willing to support, because to be quite honest, it's almost needs to go to an advisory vote, and does the public want their mill rates to increase to accommodate these programs? But maybe somebody will come up with something different, or manna will come from heaven.
Thank you, Madam Mayor. I just wanted to say how much I appreciate this conversation. I was a little, you know, I had some trepidation coming into it, and I still do, obviously, because these are critical programs for our community. But hearing the balance that you all are taking between knowing that this is urgent to figure this out for long-term sustainability of the hospital, and recognizing there's lots of conversation that needs to happen so you can figure out the right thing for the community and for the hospital. I just really thank you for finding that balance, and you know, we're here to be your partners in that conversation. So thanks.
Anything further? Mr. Bryson and then Mr. Smith.
Thank you, Madam Mayor. Man, I want to ask this as delicately as I can. While we're talking about the immediate needs to correct these non-core operations, the main goal is to make Bartlett sustainable so that it can operate. I hadn't heard it mentioned, and I was hoping that maybe somebody from the board could explain that we haven't been discussing it because we've been talking about these programs, but search has had a real impact in the medical field here in Juneau. And learning about how to be on the hospital board, learning that search doesn't need certificate of needs. They're able to operate their medical facilities with less restrictions than we're able to operate our hospital. Did I say that correctly enough? Okay. So how does that component, I mean, we're trying to save the hospital, but we have a huge competitor that is able to just go and without restriction, pick the most profitable medical procedures to perform. And that's their model. That's what they're doing. How much does that impact the hospital's viability as we're trying to correct these small programs, the overall, $138, $141 million operation that has to have had some impact on there? And then why has it not been raised tonight during this discussion as we're trying to figure out this? Is search just not a part of us coming up with these solutions as they are like the next medical player in our community? Or is that not a conversation that we can have?
Mr. Matt Mertz, you wanted to answer that?
Those are great questions, and I'm glad you raised them, Mr. Bryson. And I want to start by saying that search has absolutely changed the dynamics of healthcare in Juneau, especially dramatically in the last 5 years or so. And the big losers in this thing haven't necessarily been the hospital yet. And I think that's important. The big losers have been the other providers. If you use dental, we had Dr. Brent Tingey, come and give us comment during public comment at our board meeting in May, and very eloquently laid out the fact that we have, prior to 2019, had a very vibrant dental community here, orthodontic and dentist community here in town. And they sent their head of the dental practice to the local providers and said, we're going to start competing against you. It's probably a fair question to ask why. They're a 501c3 provider that is supposed to provide services to their beneficiaries, yet they're competing against dentists and ENTs and psychiatric providers and it's a fair question to ask why. But the next question then is, well, to what impact? And my profession, I did a lot of healthcare in my profession over better than 3 decades, both down south and up here. And there are a lot of studies around what happens to communities when they lose, number one, their sole community provider hospital, and number two, when they have monopolistic healthcare. And what we don't want to have in Juneau is monopoly healthcare. If we end up with that, the healthcare outcomes for the community will be worse. And so we absolutely have to have competition, number one, and number two, we have to have a strong community hospital. So, how do we get there? I think it's a fair question. And it's one that, the board has been discussing, especially the fact that we've had providers bring it to our attention. And we don't really have an answer for that yet, to be honest with you.
Ms. Peterson.
I actually had a coworker ask me today if the hospital was for sale and if Search was going to buy it. And there is conversation like that around. I've heard people, read little comments about it. And I think that's a real conversation. And I appreciate you bringing this up, because I don't think what I just said surprised any of you.
No, it doesn't, but that is not the topic for today.
No, it's not. But that is.
Mr. Bryson bringing it up, but that is, hopefully you guys will be working with Search and doing some information gathering there, and we can proceed with them. Did you have a question?
I had kind of a comment that followed on what Mr. Bryson had to say, but I know I will keep it short, yes, thank you. I just wanted to comment, and I've commented on this before by way of a question, but maybe I can do it without a question. In other communities that have community hospitals, it is common for the city to have some form of subsidy for the hospital. And I know we're very attuned to our own costs, but I just want to raise that. And in the context of what Mr. Bryson commented on, and then Mr. Mertz's answer, you know, if we do like some kind of raise taxes for this subsidy, the city itself would want to have a real sense of stability in the funding that it's going to provide. So that we wouldn't have the idea that, okay, 4 million this year, but it's gonna be then 3 years later, oh no, it's 8 million, oh no, now we need 12 million. So there, it's kind of like, we want the hospital to stabilize, but if a subsidy comes about, that needs to be stable too.
All right, any further comment, questions from anybody? Anybody on the screen? Nope.
Mayor.
Ms. Hughes-Candies.
Thank you, Madam Mayor. I was just going to say, just more generally following on what you had said, you talked about the number of what it potentially could be and where we might go from here and what next steps could be. So I just want to thank the hospital board. I know you're bringing some of these where it's saying or cut it. And I know that you all don't take that lightly and you also care about these services. I think this is a good spot to be in, is to have this information now, have us more on board, have us ask those questions that will lead to more detailed information, and really get the public's engagement. That would be what I would ask you to do next, and it seems like you have a good plan for that, so I appreciate it. And then just in light of the various sub-programs, I just want to say that to the community, you know, we acknowledge, or I acknowledge, I can only speak for myself, that mental health is health. So when we're talking about vital health services, you know, insurance is funny because, you know, it covers this, but not your eyeballs or your teeth bones. And we kind of, as a society, fracture that up similarly with mental health. So we really recognize that mental health is health, and we'll figure out how to take care of these projects.
All right, I have Ms. Johnston and then Wahagadok.
My voice carries. I just wanted
Not
to,
Zoom.
I just wanted to clarify, in our options section, one of the options is close or chow. But we're going to make every effort to do that handover to someone who can pick it up and continue the services. We've already started some conversations, as Mr. Mertz said. There's an organization in Anchorage that's interested in hospice and home health. Man, I cannot speak today. Hospice and home health. But there are also local organizations that we're talking to and that are reaching out to us, just to see how we can collaborate to continue these services in the community. So the closing is the option of last resort, even though they're on the same line. So that's a big reason why we're trying to get the word out into the community, so folks that have ideas and opportunities to collaborate with us can ensure that these services continue in our community.
Thanks for that clarification. Wahagadok.
Yeah, I just, appreciate what Ms. Hell said, and Ms. Hughes Ganges, I agree with both of what you've put forward, and there's a lot to digest here. I am thankful to have this time with the Bartlett Regional Hospital and to consider what pathways we can move in going forward. I am very anxious to hear what our community would like to say about our budget moving forward. And I do want to correct one thing. Most of our rural communities operate on just one hospital or just one clinic, and we're doing just fine. So, that thought process, I don't want it to get lost in translation that sometimes we don't have a choice. And sometimes, the only hospital that we do have happens to be Native Healthcare. Doesn't mean that it's any less.
Good point, Wonkadok. Thank you for that. Anything further? So, and I see someone in the audience, I won't point her out, that maybe we need a fundraiser for hospice and home health care. Just saying. Mr. President, do you have anything further?
I just want to say thank you to our staff for putting this together for us, Ian and Joe. And thank you very much. And Kim, of course, I'm looking right at you, thanking you and not using my words. And Max, thank you for being voluntold today to present this to us. Your years of experience with Bartlett and everything really shine today. And thank you very much for walking us all through this. And the board too. The board's had a couple of nights of really having some intensive work on this budget to really understand where we're at. So I think that we're going to be in a really good place as we get public comment in the next month. So thank you guys very much for showing up today.
Yes, thank you to the board for all your service, and we appreciate all you've done, and we know it's been hard work for you guys, and so we really appreciate some of you that have been around for a while. So anyway, we'll take 5 minutes, and again, thank you for those in the audience that testified. We'll take 5 minutes and let the board disappear. The assembly still has one item of business.
Do we stay at the table?
No, you can take 5. Bill user expertise, I'm adding Ms. Atkinson for someone who probably will run several seats to that list. So we have a committee of 4 instead of 3, so they better get all along. So, Ms. Hale.
Madam Mayor, may I see your list, please? Madam Mayor, I move that a committee, Assembly City Attorney Search Committee be established with Christine Wallace Chair, myself, Mr. Bryson, and Ms. Atkinson as additional members. And I ask for unanimous consent.
All right, hold one because Ms. Walgadock had a comment, I think.
No, I was just gonna say you froze all the way through what you said, Madam Mayor. We heard nothing. So, but I think Ms. Hale repeated what you said, yeah.
Ms. Hale probably did a better job of saying it. Did you guys hear the motion? Any objections? Seeing none, that's the committee. Mr. Hargrave, it's up to you now.
Okay, so on page 18 of the packet, I wrote a memo to the assembly talking about different processes you might choose to recruit and select a new city attorney. Kind of highlighted that we have a position posted and kind of how we went about talking to the deputy mayor, who was the acting mayor at the time, just to kind of get the position posted and out there to be able to start taking applications. Knowing that if you choose option 1 and select an executive search firm to kind of run the whole process for you, rather than option 2, which is running it in-house, with me as staff to the committee, then we could reverse course if needed. And then I just wanted to point out option 3, which is kind of posting it ourselves, but engaging with recruiters out there on a contingency fee basis to see if anybody wants to kind of help reach out to people and get people to apply and stuff. And those types of situations don't cost anything unless the person that the assembly selects is referred from one of those recruiters. So that's kind of where things are, and I'm just kind of, I laid out, if you choose option 2 or option 3, kind of what that process could look like based on what you did with the city manager. I included the posting, and I tried to include a time frame in the table, which is kind of aggressive if there's multiple applicants. But to get us to a point where the assembly is able to select an attorney and hopefully have them start, around the time that Mr. Palmer's leaving or shortly thereafter.
Yeah, but Mr. Palmer's thing said flexible as needed, just saying. And Mr. Hargrave, remind me, I believe for the city manager, we used the option 3, the blended effort, but I can't remember if any of the firms gave us any candidates.
We weren't able to get any recruitment firms to engage with us.
All right, so anybody have any strong say on, I'm looking at Chair Wall over there first.
Thank you, Madam Mayor. I mean, we liked the look of the blended effort for the city manager, but given that no one wanted to do what we wanted them to do, then I'm fine with in-house recruitment, option number 2. Though option 3 would be fine, but that takes time to go try to find people, so.
Mr. Bryson?
Thank you, Madam Mayor. The Bartlett CEO Recruitment Committee reported that they had 34 applicants. What do we do to get 34 applicants? That would be my question.
Hey, a lot more. But thank you for that. You can ask them. I have Mr. Kelly, Ms. Hale, and then Ms. Hughes-Gandes. Mr. Kelly.
Thank you. I wouldn't say I have a strong preference. I think my only strong preference would be not option 1. Not having gone through this before, I don't share Ms. Wall's experience, but I value her expertise. I kind of value option number 3, I think, because it gives us more options, but I don't have a strong opinion on that.
Ms. Hale and then Ms. Hughes-Gandes.
I think, thank you. I was going to say option 3, but I'm also totally on board with Ms. Wall's recommendation for 2, because that's right, we didn't get anybody showing us some great candidates. I just want to make sure that if we are going with option 2, can you describe where this is going to be advertised or how it's going to be advertised?
Mr. Hargrave.
Sure. So if you look on page 20, I listed out on number 2 under the proposed selection process. We've got it posted on Government Jobs and Indeed right now. And so that Government Jobs is NeoGov, the program we use to recruit. And Indeed is probably the biggest job posting website out there in the United States. And then once I get direction from you today, we'll engage with AML, the Alaska Bar Association. There's an Alaska Municipal Attorneys Group that has an email group or maybe a posting board. I'm not sure. I'll work with Mr. Palmer on that. And then I was just going to talk to Mr. Palmer about any others that are worth advertising with to engage with potential candidates.
Yep, and of course, and if any of us know a good attorney, please tell them to apply. Let's see, I had Ms. Hughes-Gandes and then Mr. Smith.
Thanks, Madam Mayor. I was just going to express my preference for 3. I think that's essentially 2 plus Dallas reaching out and probably getting told, we don't want you unless you pay us a fee. So why not have him reach out, just in case they change their mind?
Mr. Smith?
Echo those comments. I'm supportive of 3. Thanks.
Walgadock or Ms. Atkinson, you want to weigh in? Neither one of them look like they want to weigh in. Not option 1, though, I'm assuming. Okay, they're both nodding, not option one, so. All right, with that, Mr. Hargrave, do you need any more direction? You have a committee and you have a chair to talk with now, so what do you need from us further tonight?
I think what I'm hearing is to start with option 3, see if I can get any headhunters to engage with us and enter in agreements with them if we can, just to get some more people out there, getting word out. And then, you know, it might end up being option 2 by default, but we might be able to engage with some headhunters too.
Ms. Wall?
Thank you, Madam Mayor. Just wanted to say 2 things. First, when we did the city manager search, we had some assembly members show up to our meetings who are not on our committee and participate the whole time. So if you are interested, you are welcome to come and join us. And second, given this accelerated timeline, we'll try to get this committee together soon, but I asked Mr. Hargrave to put together a survey similar to what we did with the city manager search to get comments from the assembly and from staff on kind of the key things you'd be looking for, so the committee can use that information to come up with our screening criteria. So we'll do that soon, so keep your eyes open for it.
All right, appreciate that. Anything further? Anything further from the gallery? Mr. Barr, no? All right, with that, we are adjourned.